Good morning, everyone. I'm Ming Wu from National Taiwan University Hospital. It is my great honor and pleasure to introduce the keynote speech by Professor Ahmed El-Omar. Professor El-Omar graduated in medicine from Glasgow University, Scotland, and trained as a gastroenterologist. He worked as a visiting scholar scientist at Vanderbilt University, Tennessee, and the National Cancer Institute, United States, and was professor of gastroenterology at Aberdeen University, Scotland for 16 years before taking up the chair of medicine at St. George and the Sutherland Clinical School, University of New South Wales, Sydney, Australia. He is the editor-in-chief of the journal Gut. His research interests include all aspects of the microbiome, inflammation-driven GI cancer, and inflammatory bowel disease. He is the director of the Microbiome Research Center at St. George Hospital, Sydney. Actually, Professor El-Omar is our old friend, and he is so famous, so I don't need to talk too much. We give Professor El-Omar a big hand. Welcome.
Professor Wu, thank you very much for this very kind introduction, and good morning, ladies and gentlemen. It's always a great honor and pleasure to be back here in Taiwan. I really feel at home here. I've visited so many times. My first visit was actually in 2006, and indeed this was such a transformational visit because I made so many friends that we have to this day, and I hope to grow them more and more in the future. In fact, I'll show you a picture. This is in 2008, my next visit. This is Professor Lin, and this was actually in Kaohsiung and in Ida Hospital, perhaps the fanciest entrance to any hospital with this beautiful piano in the background. Really quite impressive, and there was a wonderful visit at that time. You'll notice that I had a little bit more hair then, and it was a little bit more black as well, so things have changed, obviously, over the years. Now, this is Chiang Chang, who was a friend of ours who used to work here in Kaohsiung before moving, and these are my two youngest sons. This is back in 2013, and as I said, we had a long friendship, and indeed, they were just with us literally just a few weeks ago in Sydney, and these are my two boys now grown up 6 years later. So really are very, very delighted to have hosted both Professor Wu and Professor Chang with us in Sydney. Now, of course, it wasn't all just work. We were able to do some research and look at some of the infrastructure that supports the research in Sydney. Now, this is just outside our Microbiome Research Center, where we are really quite keen to collaborate with as many people as possible. And I hope that by the end of this talk, there'll be an invitation for you to collaborate with us. We also have other visitors coming through. You'll probably recognize this fellow here, Professor Marty Blazer, and his wife, Gloria Dominguez-Bello. And again, they were with us just literally 3 weeks ago in Sydney. And this was a microbiome study looking at the microbiome of marsupials, which are obviously very prevalent in Australia. Again, it's just the beautiful beaches down there. So again, it's a very good destination for you to come for holidays. Now, the Microbiome Research Center in our hospital was set up about 3 years ago and established with a number of sections or themes: cancer, women's and children's health, infection, immunity, inflammation, mental health, and neuroscience, and critical care. And I show this just to show you that the microbiome really is a very exciting and revolutionary frontier in medicine. And we, the gastroenterologists, are the custodians of this microbiome. This is why our work really is very relevant to almost every discipline in medicine. And I hope that we can take that knowledge and translate it into benefit that would reduce the disease burden globally, not just in gastroenterology or gastrointestinal disease, but for almost every other human condition. Now, there is, of course, a lot of hype about the microbiome, and our job really is to concentrate on designing the proper clinical and basic studies so that we can actually deliver the translation that will benefit our patients. This is just the group that we have at the moment. It's about 25 of us, and again, we're a very, very nice, diverse group. 2/3 are women, which we're very, very proud of, and hopefully, again, we will invite some of you to become our partners and come and spend some time with us at MRC. So the microbiome, as I said, this is, when we started out in this business back in the early 2000s, it wasn't called the microbiome. We used to talk about the microflora, a wrong term, of course, because it's not plants. We're talking about microorganisms. We're outnumbered by the microorganisms, certainly in terms of number, but definitively in terms of genes. So there's 200 to 1 microbial versus human genes. And as you can imagine, this will translate into quite a major impact on our health, our physiology, and pathophysiology. Now, perhaps the most staggering statistic is that the metabolic output of the microbiome, this organ that we're carrying around mostly in our gut, is equivalent to the liver. And that's really a very important kind of contribution to your health. It stabilizes by about the age of 3, and it becomes more like the adult microbiome at that stage, unless, of course, you can influence it by a variety of different pressures from the environment. Now, so the first clinical practice point to take home is this microbiome is a new revolution, new frontier in medicine, and promises major advances in the near future. Now, one of the big questions in this field is, where does the microbiome come from? In other words, what influences that kind of acquisition of the microbiome? We assume that the in utero environment is sterile, but in fact, there is a little bit of debate about this. Some studies show that there is exposure, others say that it's just contamination. My own feeling is that the actual, the point of fertilization and the establishment of the embryo wasn't done in a laboratory with a postdoc fellow doing irradiation of that environment and sterilization. It's actually a very filthy environment and obviously full of microorganisms. So it's not inconceivable that that developing embryo will still have some kind of exposure to microbial influence throughout its in utero life. Whatever it is, by the time it emerges, it clearly has the exposure to much more microorganisms. Whether it's a normal delivery through vaginal route or cesarean section, and this is a very nice study that looked at exactly what happens with these babies a day, 3 days, and 4 months after. So they tracked those microbiota of the mother, oral, vaginal, skin, and stool, and then looked at the microbiome of the children, and showed that, in fact, the take-home message from this is that the baby acquires most of its microbiome from the mother. And there is niche selection, so the mother's gut microbiome ends up in the baby's gut, and so forth. So this is a very important concept, and that's the second clinical practice point, which is that mother transmits the microbiome to the babies, and potentially this has a huge impact on the health of the babies and the health of the world, because if we are passing on defective or dysbiotic microbiota, this can have an impact on the health of the next generation. And indeed, this is borne out with this study published this year in Gut, and this looked at infants born to mothers with inflammatory bowel disease. And if you look at the gut microbiome of those babies and you actually transplant it into a mouse model, a germ-free mouse model, you're actually transferring those abnormalities in the adaptive immune system. So the baby of an IBD mother will have in its microbiome the factors that can influence negatively the immune response. This is a very important concept, and there are so many other examples, not just in IBD, but other conditions. Now, another very fascinating concept is this development of the microbiome during pregnancy. And I spend a long time talking about this because I think if we get that phase of development correctly, in other words, producing the next generation and giving that next generation a proper microbiome, I think we can save a lot of human disease. Now, this study was published quite a number of years now. This is 2012, so it looks like an old study, but it's still quite a major important study. Now, this looked at mothers in trimester 1 and trimester 3, and then looked at their gut microbiome and showed that, in fact, the gut microbiome of these women that delivered normal, healthy babies and had normal pregnancies was, in fact, less diverse as the pregnancy went on. So this is the opposite of what we preach. We always say that high diversity is a good thing in the microbiome. But these women, actually, that had a normal pregnancy developed a less diverse, a more aggressive, more pro-inflammatory type of microbiome in trimester 3 compared to trimester 1. And indeed, when you take that stool from those women in trimester 1 or trimester 3 and then transplanted into these mouse models, normal mice. The ones that receive the trimester 1 are normal. They don't develop any other consequences. But the mice that get the trimester 3 stool become obese. And of course, we're all familiar with what happens during pregnancy, is that the woman accumulates fat during pregnancy, despite not eating more or not using more calories, and despite actually spending more energy. So the mother is accumulating fat. And you think, why is this happening? Why is fat accumulation occurring during pregnancy, a normal pregnancy? And it's clearly as a safety mechanism in case of famine, in case you cannot guarantee the next meal. As a hunter-gatherer kind of species, this is a reasonable, good safety kind of net. However, the problem is that we are no longer hunter-gatherers. We are not living in a situation where your caloric intake is unpredictable. In fact, we are bombarded by obesogenic diet all the time. So you can imagine if a mother comes into pregnancy already with a dysbiosis, this, of course, can overshoot, and then you can develop complications like gestational diabetes, gross weight gain, and all the other negative complications. So this is a very important and active area of research, and I think it promises to deliver quite a lot of benefit clinically. Now, the other question is, what is more important? Is it the environment or your host genetics in terms of determining the structure and composition of your microbiome? And this was addressed in a very nice study published last year in Nature, looking at families that come from different ethnic backgrounds. The setting here was in Israel. So different ethnic backgrounds cohabiting in the same environment, and then looked at the effect of host genetics versus the kind of environmental background. And in fact showed very nicely that the host genetics contribute very little to the composition of the microbiome. So it's mostly environment that determines what's in your gut. And this is, again, a very important concept. And the take-home message is that because it's something environmental, potentially you can manipulate this microbiome when, in fact, you cannot change your genetics. You're stuck with your genes. But if you can change something environmental, you at least have the potential for influencing the natural history of disease. And this is a very important concept and a take-home message. This was reinforced by another study that was published in Nature Medicine, again last year, looking at Guangdong province. It's a large province with about 120 million population. That's 4 times the population of Australia. And they divided this into 14 districts, and then they looked at the microbiome. So about 7,000 subjects that were studied. And they wanted to find out what is the most important predictor of that composition, that influences the composition of the microbiome. And it turns out to be, in fact, geography. So District 1 is closer to District 2, but it's different from District 13 or 14. And the farther away that you go, the more difference in that composition. And geography was by far the most important factor. But of course, geography is a surrogate marker for the environmental exposures. So the food that you eat, where it's grown, the soil that it's grown, the air that you breathe and so forth. If you come from an industrialized part versus a rural one or a mountainous one, all of these will have an impact, of course, on your microbiome. Now, the important part of that study was when they tried to formulate signatures of disease, for example, metabolic syndrome or diabetes and so forth. Again, the signature that you can identify in District 1 was not the same in District 14. Again, if you're separated by geography, this will have an impact on your predictive signatures. And this is, of course, a very important concept, because if you're designing studies in your country and you want to define a signature for colorectal cancer or for diabetes, you have to be aware of that fact. If it's all entirely based on taxonomy, if it's just based on who is there, what bugs are actually in that particular stool sample. Now, this is another interesting study. It's quite complex kind of bioinformatics and so forth. But the take-home message is that, in fact, you might look at different people's microbiomes and see that they are, in fact, different. Like, for example, the one that I showed you from China that looked at Guangdong province. But in fact, within that, if you just dissect into the minutiae, you'll find a kind of a hardcore group of microorganisms and genes within those microorganisms where there is a bit of stability in terms of predicting a particular association with health or microbial adaptation. So with little fancier bioinformatics, it is possible to define a more consistent signature, but requires obviously quite sophisticated bioinformatics and sequencing. Now, of course, we're gastroenterologists. We're familiar with the gut barrier, and the essence of the microbiome-related diseases centers around this slide, which is essentially the dysbiosis, the imbalance between the good and the bad bacteria, the induction of low-grade chronic inflammation, the weakening of that gut barrier and the gap junctions and so forth, and the leakiness of that gut barrier. And of course, if you have a leaky barrier, there is an invitation for translocation. So either microorganisms or their metabolites or other things can translocate from the gut elsewhere. They go at different compartments. It could be into the lymph glands or the lymph circulation. It could go into the circulation and so forth. And this explains how they become relevant to other diseases that are distant from the gut. But just to remind you again, all of these little microorganisms that are living in your gut or in your lungs or on the skin or whatever, they're actually metabolizing and digesting and dealing with whatever we give them. So if you're dumping indigestible fiber or xenobiotic substances or drugs or whatever into the gut, these are the bugs that actually work on them, and they're little factories. And what they produce are metabolites that then have an impact and interact with receptors. For example, if you're generating from your carbohydrate fermentation, your short-chain fatty acids, well, these will act on your GPR43 and other receptors, and these will influence the colonocyte health, your immune system, and so forth. So these are little factors that are producing these metabolites, and this is why we are essentially all united in biochemistry, because it's all about chemicals that will have interaction with receptors. It doesn't matter whether this is in the gut or in the lungs or in the kidneys. It's all the same biochemistry that unites all of us. And I think this is, again, a very important take-home message. Now, there are so many causes of dysbiosis, and you're all familiar with this. Of course, the most important is diet. And diet is really is what you're feeding those microbiota, so that makes sense. Of course, it's not just the food, but it's the additives that we add to the diet, like emulsifiers and artificial sweeteners and all sorts of E-compounds and the rest of it. These are obviously have an impact on your microbiome. The other very important one is physical activity or exercise, and I think this is something that we all know. If you're eating healthy and you're exercising, it protects you from almost all diseases known to humankind. Lifestyle like smoking and alcohol, aging, infections, antibiotics, of course, wipe out large proportions of your microbiome. But more importantly, and this is an emerging concept, is the role of other medications. These are non-antibiotic medications that will also have a very profound effect on your microbiome, as I will show you later. Now, this is a very interesting study. It made big headlines in the press and so forth because of its unique nature and the unique kind of subjects that took part of it. This is looking at marathon runners. So this is the Boston Marathon, and they had tracked those athletes 5 days before and 5 days after the marathon itself. And what they could show that, in fact, the event itself, that 26 miles of running, had an impact on your microbiome and led to proliferation of this microbe called Veillonella, a particular strain called Veillonella atypia. So this was actually proliferated after the event. And indeed, when you take Veillonella and you use it in an animal model, a mouse model, now this is a mouse that is trained to run on a treadmill until it reaches exhaustive stage where it can't run anymore. So these run until they drop, essentially. But if you give them this Veillonella atypia, it increases their maximal or exhaustive treadmill run time by about 15%. So it enhances that performance of those athletic mice that are trained to run on treadmills. And now they also worked out the mechanism of this, and it turns out that when you all go to the gym and you exercise and you have pain in your muscles, this is due to lactic acid. This lactic acid actually eventually makes it into across the epithelial barrier into the lumen of the gut. And if you've got the right bugs, or the ones that are able to then metabolize this, you can change this lactic acid into propionate. So lactate to propionate is what happens, and it's the propionate that is responsible for your enhanced performance. It's quite a fancy concept. But in fact, you might think that this is quite an esoteric finding. It's relevant to marathon runners. But think of the potential clinical use of this, in the context of, say, cancer or sarcopenia, weight loss, anorexia, the patients that are losing weight. This could actually enhance their performance. And again, it's a very promising and exciting development. So the take-home message is that if you understand the role of the microbiome and metabolic pathways, this is relevant for therapeutics and for also preventative measures. Now, effective medication, because one of our defining privileges as doctors is that we are able to prescribe medications. And quite often, we do this in good faith, of course, but there are so many side effects that we never understand. There are, sort of mysterious ways that drugs work. In some people, it's efficacious, in others, it's not, and we never really understand why, even despite our kind of knowledge of physiology. It just doesn't make sense. Well, it turns out that, in fact, a lot of the drugs that we give to patients will have a profound effect on the microbiome. And this is a study that I think is one of the most important ones published in this field. This was last year in Nature, that took about 1,100 non-antibiotic medications and tested them directly on a panel of 40 commensals, and showed that, in fact, these are commensals that grow in the gut. These are kind of commonly found commensals, and showed that, in fact, about a quarter, 24% of those non-antibiotic medications can actually have a direct killing effect on some of those commensal microbiota. Now, this is a very, very important concept, because we never understand why somebody gets diarrhea, or somebody gets constipation, or somebody gets a headache or a skin rash. These are all kind of mysterious side effects, but this gives you an opportunity to try and figure out what's going on. And indeed, if you look at the list of those drugs and look at the groups of drugs that they looked at, the number one in terms of its impact on the commensal microbiota was the antipsychotics. Antipsychotics that we use for things like schizophrenia and depression. Now, it's not kind of by chance that, in fact, one of the commonest side effects of antipsychotic treatment in patients with schizophrenia is weight gain, obesity, diabetes, and increased cardiovascular risk. And it turns out that, in fact, some of those changes in the microbiota are quite relevant. They have, they knock off their Akkermansia, which protects you from these outcomes. And I think it's a very exciting area of research that is relevant to mental health and psychiatry. Another one, of course, is the proton pump inhibitors. We all know this because apart from inhibiting your acid and allowing ingested bacteria to make it distally, they also have a direct killing effect on those microbiota. So when we're talking about H. pylori eradication, you never know. It might actually, the PPIs might be doing some good in terms of knocking off the H. pylori as well, which would be quite pleasant. But the other one is morphine. Morphine now, there's an opioid epidemic, and this is very important in the news in the United States in particular. And there's some beautiful studies showing that, in fact, when you give morphine, you influence the microbiome and you lead to proliferation of certain types of bacteria that sensitize the host to pain. So the more you give of it, the more pain you feel, in fact. And it's really a beautiful literature. I don't have time to go through it today, but it's quite exciting. Now, PPIs, as I said, this is absolutely no debate about this, is that they can have a negative effect on your microbiome. Some beautiful studies published, large studies, again, showing the concept of oralization of the gut microbiome. So basically, you have more oral microbiota settling in your gut, and this, now there are many associations with that, and I'm not here to trash the PPIs or to defend them, but I just ask you to become aware of the fact that it has an impact on your microbiome. Now, this is another study just published in Gut, and it shows looking at the children again, antibiotic and acid suppression medication during early childhood. So this is like in the first 2 years or so, and looking at the risk of developing things like obesity. So if you look at this, if you had none of these medications, or if you had one or two, for example, a PPI or a H2 antagonist and antibiotics, so obviously the more of these, the higher the risk of you developing obesity later in life. And one assumes that this is all being mediated through the microbiome. So the clinical practice point is that the medications that we prescribe have profound effects on the microbiome, and this in turn has profound effects on the efficacy and potential side effects of the drugs that we use. Gut-brain connection. Now, as I said, we are blessed in gastroenterology in having all of these relevant diseases all now within our reach, and if you keep track of what we publish in gut, I'm sure you'll be surprised to see papers looking at preeclampsia or dementia. This is all because we are the custodians of the gut microbiome, and it's relevant to every other discipline in medicine. So I think it's actually appropriate that we publish this through our GI journals. Now, the gut-brain barrier is very well established. It's the gut is the heaviest innervated organ outside of the central nervous system. It's the largest immune system. It's the largest endocrine system. Essentially, it's directly wired by nerves, your vagus nerve. It's directly wired by an immune system, and of course the hormones that circulate. But more importantly, the gut microbiota synthesize a lot of the neurotransmitters that are relevant to all of these interactions and so forth. So it's not a surprise, and in fact, this gut-brain axis is incredibly important. And we're all familiar with our patients with IBD or other IBS. If you have diarrhea or constipation, you're always miserable, or you feel depressed and so forth. They're directly interlinked, of course. And there's been a lot of exciting work recently on the role of the gut microbiome in things like Parkinson's disease and depression and psychosis and so forth. So I think just watch this space. I won't have time to do this. Now, the cardiovascular system, of course, doesn't escape from this revolution. And again, the mechanisms are being worked out. This is a beautiful review, again, by one of the leading groups in this, Stanley Hazen in the US is a very nice one. And again, it's all about the metabolites that are being produced and being linked to pathologies such as atherosclerosis, obesity, type 2 diabetes, chronic kidney disease, and so forth. And again, this is just a very nice reference published this year. This slide just shows you the kind of the potential pathways, and we're aware of the negative effects of red meat, for example, which is, these are the kind of the dietary components that would be rich in choline and carnitine. And these can be metabolized in the gut to TMA, which is trimethylamine, and in the liver you produce TMAO, which is the oxide. And this, of course, is a highly atherogenic substance. And indeed, in the cardiovascular field, this is one of the kind of the superstars at the moment. There's a lot of interest in it, just like CRP was a few years ago. Now, if you want a very nice paper on this, just again published this year from our distinguished chairman's group, looking at defining or designing an oral carnitine challenge test, specifically to look at this TMAO producer phenotype. So again, there's a lot of interest in this field, and I think I urge you to go and read this beautiful paper. Now, the microbiome in cancer, of course, again, hasn't escaped this revolution, both in terms of the pathogenesis of all of these cancers that are collectively the largest burden of all the cancers. We are responsible for dealing with this. But in terms of the microbiome, it's very, very well established. The concept of driver bacteria that are there at the beginning and then disappear towards the end. And of course, the passenger bacteria that kind of get you there in terms of getting to cancer. And the classic example, the Fusobacteria nucleatum, which seems to be cropping up quite a bit in a lot of cancer signatures. Now, we understand a lot about the microbiome, and particularly, for example, something like colorectal cancer. This is a paper that shows this increasing incidence of colorectal cancer in young adults. A paper that comes from Europe, looked at more than 140 million European population from 20 different countries, and showed this alarming increase in young colorectal cancers, especially between the age of 20 and 49. Now, obviously we have to figure out why this is happening, and it can't be a rapid change in the genes, obviously, so it must be some kind of environmental exposure. And the next paper perhaps offers potentially an explanation for this, and this is obviously open for research and discussion. Another paper that's published looking at the oral antibiotic use and the risk of colorectal cancer, and this came from the United Kingdom, and again showed that in fact, if you take antibiotics like, say, the penicillins, amoxicillin, for example, it increases your risk of developing colonic cancer. But in fact, there's a separation between colonic and rectal cancer, which seems to be protected with the use of antibiotics, particularly use of antibiotics like tetracyclines and so forth. So now, this is not definitive, of course. It doesn't. It's not mechanistic, but it's telling us to look at this in a bit more detail and figure out what's going on. Now, I won't have time to go through these very quickly, but I just want to recognize the work that's come from the Chinese University of Hong Kong, and Sunny Wong is sitting here, and these are beautiful papers that they published over the last couple of years, again, looking at the pathogenesis of the microbiome in relation to colorectal cancer. This is when you take stool from cancer patients and stool from non-cancer patients and put them in an animal model, and what you show is that you can accelerate the neoplastic process if you transplant stool from cancer patients. There is something in that stool that is kind of promoting and enhancing that carcinogenic process. They also showed that this is, if you look at a microbial signature combined with your regular fecal immunochemical testing, that you can enhance the ability to diagnose significant lesions, for example, advanced adenomas and cancer, by quite a significant proportion. Now, this is only one bug, the Fusobacteria. Imagine if you had a very robust signature or microbial signature, you can imagine that this would become really, really quite important clinically. Also, in terms of the prognosis, this is a paper looking at the content of the tumors of Fusobacteria DNA, and showed quite nicely that the higher the Fusobacteria content, the worse that you do in terms of prognosis of the colorectal cancer. Finally, this is, again, a beautiful study that looked at these Fusobacteria-positive colon cancers, and of course, about half of these will metastasize to the liver, and half of these metastases will also be Fuso-positive. And the concept here is that metastases can take with them their own microbiome. They can take with them microorganisms and travel through the blood and end up in another organ. This is a very revolutionary concept because we never think about this. We never think that, in fact, these metastases actually have a microbiome that can impact on what happens to those metastases and how it kills the patients. And indeed, in that study, if you give metronidazole in those animal models that have had these metastases, you can reduce the disease burden, you can reduce the tumor burden. So the take-home message, the gut microbiome is directly relevant to the pathogenesis, diagnosis, treatment, and prognosis of GI cancers. How much time do I have, Stanley? Just yeah. Oh, plenty of time. So this is nice because I really wanted to tell you about this, about pancreatic cancer, because it's the most horrible of all the cancers that we have to deal with. And indeed, we really are stuck. We haven't made any progress. The 5-year survival rate is still around 8%, which is really quite miserable. But perhaps this microbiome revolution can offer an opportunity, at least, to investigate the pathogenesis and offer some hope. Now, for some time now, we've had a number of papers telling us that, in fact, the oral microbiome might be relevant to pancreatic cancer. We don't know why, but this is epidemiology. It's just showing that, in fact, if you look at the oral microbiome, it's linked somehow to the risk of pancreatic cancer. But if you think about it as endoscopists, you should appreciate that, in fact, whatever is in your mouth, you swallow this, it will pass through your stomach, and then it will be bathing the duodenal segment. And that is where all the plumbing for the pancreas is. That's where all the ducts are. It's a glandular structure that secretes enzymes and so forth. These enzymes have to come out. And if there's any communication with the outside world, it means that reflux can go back in. So essentially, whatever is actually in that segment could potentially end up in the pancreas. It's very simple. I mean, but we've always assumed that the pancreas, just like we assume that in utero is sterile, it's not sterile. It has a microbiome. It has a microbial kind of complement. So this study shows you that, in fact, there is a link between the oral microbiome and pancreatic cancer. But the field was, again, very stuck until a couple of papers were published, one in 2018 and one this year. This is the first one. It was published from George Miller's group in NYU. And this paper struggled quite a bit. I know this because it must have been submitted to a number of high-impact journals. And when you read the paper, you'll appreciate that this has happened. I can tell this as an editor because there are so many experiments that have been added and added and added, and that's all of these critical reviewers not believing the story and asking for more confirmation and more confirmation. It's actually a wonderful piece of work, and in fact, it's very revolutionary. And in it, they demonstrate very clearly that what you have in your oral cavity can end up directly in your pancreas because they have had them labeled. So they were gavaging microorganisms that had the label that you can trace, like a green fluorescent protein, for example, that you can trace in the pancreas, first thing. Second, they wanted to see whether these are actually found and enriched in human as well as animal models of pancreatic cancer, and the answer is yes. And then they set about trying to understand the mechanism by which this microbiome can actually influence the risk of pancreatic ductal adenocarcinoma. Now, I don't have time to go through all of the different parts of it, but the conclusion was that the microbiome promotes this pancreatic ductal adenocarcinoma progression by inducing peritumoral innate and adaptive immune suppression. So basically, it's causing your immune system to become less aggressive in the pancreas, and you're not able to kill off your rogue or kind of aberrant clones that have developed into cancer. So this is a very interesting. So that was the first paper, and was followed earlier this year, just a few weeks ago, by this paper published in Cell that looked at 2 cohorts of pancreatic cancer patients. And I told you at the beginning that the survival rate is less than 8%. So those 8% that survive long, in other words, more than 5 years, they're called long-term survivors, okay? Long-term survivors. But the default is short-term survival. And they had at Johns Hopkins and MD Anderson 2 different cohorts that looked at these long-term survivors versus short-term survivals, and they tried to distinguish any features at all with using any parameters that are available to them why the long-term survivals do better. And they couldn't. Yet, when they finally started looking at the microbiome, this is looking at the tumoral microbiome, they found that in fact all the features that we ascribe to a healthy, balanced, diverse microbiome are found in the long-term survivors. So a signature of microbial parameters actually could predict or could distinguish and differentiate those long-term survivals from the short-term survivals. Now, this is a very sophisticated paper. I won't have time to go through all of it, but it's really, really quite exciting in terms of offering an opportunity to understand why they do better. Now, of course, they had animal models, and exactly the same concept. They were able to reproduce this, and also, you could actually give these mice what's missing to make it into a diverse or a healthier microbiome, and you can influence the pathogenesis of that disease. So, very exciting stuff. Now, cancer treatment, of course, it's not just the pathogenesis and everything else, but cancer treatment is directly affected by your microbiome, because quite often your drugs that you're giving actually get metabolized by the microbiome in your body to release the active moiety or to release something that then causes side effects and so forth. So these are all relevant, and this is, again, a very nice review looking at the gut microbiome modulation of chemotherapy efficacy and toxicity. If you're interested, take a note of it, and they define these beautiful 5 parameters called timer, the translocation, immunomodulation, metabolism, enzymatic degradation, and reduced diversity. These are all the different mechanisms, and it goes through all of the different types of chemotherapeutic agents that are used. And this is yet another excellent, these are all excellent papers published in the top journals, and this is looking at fusobacteria again, this kind of villain of the microbiome world, promotes chemoresistance to colorectal cancer by modulating autophagy. Again, a beautiful paper that looked at the mechanisms. Again, we won't have time to go through this in detail. But perhaps the biggest transformation was the immunotherapy, because this is the most kind of exciting part of oncology practice, is the use of chemotherapy, immunotherapy in conditions like melanoma, for example, where it was invariably fatal, but now we can almost cure it even with very advanced metastatic disease, and that was all due to the immunotherapy. Now, for some bizarre reason, and I don't know how they got the kind of inspiration to look at this, but 3 independent groups looked at the gut microbiome signatures to see whether they can predict response to immunotherapy. And they were able to show, and these were published back-to-back, 3 papers back-to-back in Science last year. 2 were on melanoma, and 1 was in non-small cell lung cancer and renal cell cancer. And again, they showed that you could predict response to immunotherapy by your stool microbiome signature, and indeed had all the parameters, the diversity, the increased good guys, the reduction of the bad guys, and so forth, exactly the same principles that we're seeing across different diseases. Now, one of those studies that looked at the renal cell cancer, the Rout et al. Paper, discovered that in fact what's missing is the Akkermansia story. And indeed, if they gavaged Akkermansia to these mice that were non-responders, they turned into responders to the immunotherapy, so suggesting that is perhaps potentially useful. Now, the take-home message of this is actually there are clinical trials ongoing right now, for example, at MD Anderson, using FMT of responding patients, giving it to patients who are non-responsive. Now, so this is already entered into the clinical arena, and I think it's just a matter of time in the next year or 2 when you start seeing these papers coming through to see whether this has actually translated into benefit or not. Now, the interesting thing about these 3 papers that I showed you is that the signatures were different. So if you looked at who's there, you can't have one uniform signature that predicts responsiveness in all of them. And indeed, this was analyzed by Christian Joban and his colleague, and they found out that, in fact, if you look just at who's there, it won't be informative. But if you looked at what they're doing, potentially functional signature, that is far more consistent across all of these 3 papers. Now, in the interest of time, I think the take-home message here is that if you want to actually define a signature, so far we've been concentrating on the simplest thing, which is 16S RNA signatures. This is just taxonomy. It will be different across every other population. But if you have a multi-omic approach that combines, metagenomics, for example, with transcriptomics, with metabolomics, you will have a much more robust signature, and I think this will deliver far more clinical benefit. Now, these are the ways that you can manipulate the microbiome, and sadly, we're not going to have time to go through all of them, but diet is very important. Probiotics and prebiotics are valid in concept, but in reality, all the products that we have on the shelf are actually just food supplements. They've never had to go through the rigor of validation in a clinical trial. No one is interested in actually testing whether they work or not, because this is of commercial benefit. So I'll have to skip through these because of the interest of time. Sorry about this. These are just the studies that looked at the probiotics and published in Cell. If you want to take a reference, I'm happy to send them to you. But just the next generation probiotics and this story of the Akkermansia, which seems to protect you from obesity and diabetes and so forth. And indeed, this has already filtered into clinical practice. Not clinical practice, sorry, in the clinical domain, because the initial work with this outer membrane protein was very encouraging in terms of obesity and diabetes. And this is the first clinical trial that was published earlier this year in Nature Medicine. 3 months of Akkermansia, it was safe. And preliminary study results suggest that it has a positive effect in metabolic parameters. FMT, now this huge session on FMT. It's not perhaps the most palatable of all of the treatments, but I'm sure you can work on it and define this concept of the super donor, which ultimately will be the kind of the way forward is defining what's missing and giving what is needed. So final slide is just about precision medicine. We're in the era of precision medicine, and hopefully in the next 10 years or so, you'll be able to come to your doctor. They will take some blood tests, some stool tests, some other microbiome things, define what's missing, and go and manufacture something specifically for you that would replenish or allow natural proliferation of what's missing, and hopefully channel everything through clinical trials. It's got to go through clinical trials to provide the clinical evidence base. Thank you so much for your attention.
Thank you very much for this outstanding speech. As a gastroenterologist, we are in the era of microbiome, and after Omar's lecture, I think we agree it is the best time for gastroenterology to tackle different issues from the viewpoint of microbiome. We can offer 1 or 2 questions. Any question or comment? Yeah, Joseph.
Hi, I'm glad that I can just catch the second half of your lecture. I always, while feel excited about these findings of microbiome in pathogenesis and in prediction of treatment response, but we always see these studies include not a very large number of patients. And with huge number of microbial species or families that we're talking about, my question is, what is the statistical basis for this? So how do you handle this problem?
Yes, and this is why I said right at the beginning that it's our duty and responsibility to control the hype. There's an opportunity here, but because technology is advancing so fast, and if you stop relying on just describing who's there, which, as you rightly said, most of these studies are small, and you have different signatures across the different geographic areas. But if it is truly a multi-omic approach, and it's adequately funded, and you're able to definitively, confirm those signatures, I think it has a huge potential, because it's all about the metabolomics. It's all about what's being produced that will influence the interaction with the host. And for that, I think once you define that robust signature and do the clinical trials that are adequately powered, you will get the answers. So the take-home message is that this is all very promising. I share your kind of concern that we're running ahead of ourselves. The worst thing that could happen is that we start having these biotech companies springing up and either having diagnostic kits or having metabolite products without actually having the clinical evidence base. So let's not spoil it. I think we have a great opportunity, and let's just confirm this and bring it home in the next 10 years or so.
Thank you. On behalf of the society, I would like to present a certificate for appreciation of the outstanding speech.
invite Professor Tajiri from Japan to give an opening remark for this luncheon seminar. So first of all, I would like to introduce Professor Tajiri, although many of you already are very familiar with Professor Tajiri. So Professor Tajiri is the ex-president of Japanese Gastroenterological Endoscopy Society, and he is currently the senior advisor of this society and the professor in the Department of Innovative International Endoscopy Research at GK University School of Medicine, Tokyo, Japan. And Professor Tajiri has been very active as Vice President of Asia Pacific Society for Digestive Endoscopy, APSDE, and also serving as the World Endoscopy Organization, WEO, President-elect, and will be WEO President from 2022. Let's welcome Professor Tajiri.
Thank you. I'm very honored to speak our opening remarks in this memorial lunch symposium. Olympus Company will celebrate the 100th anniversary of its founding this October. Olympus Company manufactured the gastric camera to aid in the early diagnosis and early detection of gastric cancer. The founder at that time started from the desire to create something unique. The spirit has since grown dramatically and led to the development of apparatus, equipment for endoscopy today. And Olympus will aim to transform into more flexible and stronger company in order to continue sustainable growth to make people's life healthier, safer, and more fulfilling. This slide shows the technological change of Olympus company these 10 years in the field of insertion, such as responsible
Good afternoon, ladies and gentlemen. My name is Joseph Song. I'm very honored to chair the chairman's lecture this afternoon to be given by Professor Wu Mingxian. Professor Wu graduated with very distinguished results from the National Taiwan University, and he has subsequently joined as a faculty member of the College of Medicine at the National Taiwan University and received numerous awards. All along this year, his research interests focus on gastrointestinal malignancy, particularly gastric cancer and Helicobacter pylori infection. Today, he is going to give us a lecture entitled Beneficial Effects of Helicobacter pylori Eradication Beyond the Stomach. Please welcome Professor Hu.
Thank you very much for Joseph's very kind introduction. This is a memorial picture. You know, today is Teacher's Day of Taiwan. I will express my sincere thanks to Joseph and Francis. Actually, I remember I visited Chinese University of Hong Kong in year 2004, 1 year after SARS attack. And Joseph has told me a lot about how to organize the team, how to do important clinical research. The discovery of Helicobacter pylori has opened up a new era in upper GI disease. You can see the two pictures. I have getting older and older. The first picture is taken in year 1994, the 10-year anniversary of after H. pylori discovery. This meeting is organized and chaired by Professor David Graham. Perhaps David Graham is there at Houston. When I meet Benny Marshall, I told to Professor Lin, this should be Benny Marshall. And you can see he takes a newspaper in his hand. And after 10 years, in year 2004, Benny Marshall celebrate 20 years after Helicobacter pylori discovery. You can see my hair getting looser and loose. And the year 2005, Benny Marshall and Robin Warren won a Nobel Prize. So my talk will include two parts. The first part is after Nobel Prize, how about important research in Helicobacter pylori? The first question is why one bacteria can lead to so many diseases. Another is how to translate our research on prevention and early treatment. And the second part is the issue and the concern in the era. Particularly, we use Helicobacter pylori in screening or asymptomatic subject. We call it mass eradication of Helicobacter pylori. And how to select optimal regimen. And how about the long-term change of microbiota and the effect beyond stomach. This is the holy grail in Helicobacter pylori research after Nobel Prize. And that's my personal opinion. The first is what mechanism lead to disease in certain subject. And the second question is how to translate our knowledge into clinical practice, such as prevention of gastric cancer. This is the natural cause of Helicobacter pylori infection. About 15% of patients will develop peptic ulcer, and about 1% of them will develop gastric cancer. And a very, very rare portion of them will develop gastric lymphoma. The majority of them remain in gastritis status. So Helicobacter pylori alone is not sufficient to cause gastric cancer, but it is important to lead to chronic gastritis, and then will develop a lot of disease. So we established a Helicobacter pylori study group, including clinical medicine, pharmacology, and biochemistry. So let's our opinion. The development of different diseases depend on the extent of gastritis, which is determined by Helicobacter pylori resistance factor, genetic susceptibility, and the lifestyle, especially some environmental factor, for example, smoking, low vegetable, and high salt. These three factors combine together to lead to more severe infection, more severe inflammation, and lead to disease. So we do several studies about resistance factor, and also we do some so-called host factor. However, to use this resistance factor and host factor for screening and then to eradicate Helicobacter pylori in a population is difficult. It is simple, just screening Helicobacter pylori and to eradicate, to prevent gastroduodenal disease. So we focus on how to translate this knowledge into our clinical practice, especially on prevention. Actually, eradication of Helicobacter pylori not only can cure gastric lymphoma, can also prevent occurrence of peptic ulcer and gastric malignancy. So we select a high-risk community in Taiwan. It's Mazu Island. This island has 3 times higher gastric cancer mortality. And the Helicobacter pylori infection rate in this island is very high, near 70%. Also, this island eat very salty food. So after 5 years, from year 2004 to 2009, after we screen Helicobacter pylori in this island and give eradication, we find about 80% reduction of atrophic gastritis and 67% reduction of peptic ulcer. And after 12 years follow-up, 47%, near 50% reduction of gastric cancer. So we also perform a meta-analysis, and this meta-analysis show very similar result in our Mazu study. That means eradication of Helicobacter pylori can reduce 50% of incidence of gastric cancer. However, during this kind of project, actually you encounter a asymptomatic patient, and the Helicobacter pylori eradication, the regimen is not 100%. And some will have a concern about antibiotic resistance. So actually in this kind of community screening, you have a theoretical and practical consideration. Helicobacter pylori eradication rate depends on antibiotic resistance and the patient compliance. If you have no antibiotic resistance, the problem then is to use the least amount of antibiotic to eradicate. However, antibiotic resistance is a very critical problem in our clinical practice. This slide shows Helicobacter eradication rate in different geographic regions will decline dramatically as antibiotic resistance increase. This is our recent review in Asia Pacific regions. Actually, the 3 most important antibiotics in our clinical practice have a very higher antibiotic resistance. Metronidazole is 45%, clarithromycin is 21%, and the levofloxacin is 27%. So to resolve this issue, we form a Taiwan GI disease and helicobacter pylori clinical trial consortium that include 11 centers in Taiwan. And we screen the primary resistance of Helicobacter pylori in Taiwan. And that's the current situation. Claritomycin is about 10 to 50%, and metronidazole 20 to 40%, and levofloxacin is 10 to 15%. And we conduct a series of clinical trials to find the optimal regimen, especially in first line, second line, and the rescue regimen in Taiwan. This is the second line. In second line study, especially for the antibiotic levofloxacin, it is suitable for second line, but cannot be used in the first line. And for those who has failed twice, we call it refractory Helicobacter pylori infection. We also conduct a trial about genotypic or empirical. So we have published a series of how to eradicate Helicobacter pylori by randomized clinical trial. And this is just published in Helicobacter, and our team's research ran the 2 and the 4th. Of course, the number 1 is Professor Margot's. It's cited most frequently. And we developed our Taiwan guideline for Helicobacter pylori eradication based on our clinical trial data. During the practice, I have found some very interesting case. For example, we find some patient with Helicobacter pylori negative Guthrie-Marr lymphoma. However, clinicians still prescribe antibiotic for this patient. And about 30% of them, matoma disappear. However, we do not eradicate Helicobacter pylori because in this subset of patients, they do not have Helicobacter pylori infection. So antibiotic must kill other bacteria. So we put our focus on gut microbiota because we know in addition to Helicobacter pylori, there are still a number of bacteria or microorganisms can lead to GI disease. And this gut microbiota exert their effect, particularly systemic effect, through metabolic and immune effect. For example, immune signal can be through microbiome-associated molecular patterns such as lipopolysaccharide, peptidoglycan. And metabolic signal is also important, just like previously reviewed by Professor Eoma. So through immune and metabolic effect, this dysbiosis of gut microbiota can lead to a variety of disease, not only restricted in GI tract, but also other systems. So this is a so-called common ground hypothesis, so-called dysbiotic gut microbiota lead to leaky gut syndrome. Professor Eoma also had mentioned this abstract. So dysbiosis of gut microbiota may be related to different disease. For example, it will lead to cardiovascular disease. For example, it can lead to central nervous system disease. The interesting and very controversial aspect is whether Helicobacter pylori infection will have extra Guthrie manifestation. We focus on 2 issues. One is colorectal neoplasm, and another is diabetes. Helicobacter pylori infection is related to colon cancer according to many epidemiological studies. Why Helicobacter pylori can be related to colorectal cancer? There are two explanations. One is direct effect, but in my personal opinion, direct effect is not possible. It should be due to indirect effect. This is Dr. Wu's study in their retrospective cohort at McCain Memorial Hospital. Their results show after Helicobacter pylori eradication, colorectal adenoma risk indeed decreased. And in my other interest is whether Helicobacter pylori has a metabolic effect, particularly diabetes. We cooperate with our metabolic specialist. They has a cohort, prospective cohort. Actually, their results show H. pylori infection is not related to diabetes. However, gastric atrophy can predict the occurrence of diabetes. Gastric atrophy increases the incidence of diabetes. So from these two studies, my personal assumption is Helicobacter pylori infection can lead to disturbance of gastric physiology. And the disturbance of gastric physiology, especially decreased acid secretion, will lead to the similar effect just you prescribe a proton pump inhibitor to patients. So your gut microbiota will become dominated by oral flora. And our antibiotic treatment not only has an effect on gastric Helicobacter pylori, but this antibiotic may have effect on gut microbiota. So we focus on long-term effect of Helicobacter pylori eradication, in particular on dysbiosis and obesity or other metabolic disorder. This is our recent result. We compare 3 regimens, 14-day triple therapy, 10-day concomitant therapy, and the 10-day Bismuth quadruple therapy. As shown, 10-day triple therapy, both 3 regimens will have a great disturbance on gut microbiota after 2 weeks. Since 8 weeks, the gut microbiota or triple therapy recover gradually. And after 1 year, the gut microbiota recover completely. However, 10-day concomitant therapy and the 10-day Bismuth quadruple therapy, the situation is different from 14-day triple therapy. In these 2 regimens, the gut microbiota do not completely recover even after 1 year. So this is the summary, especially focused on the alteration of gut microbiota through stool sample examination. For 14-day triple therapy, the gut microbiota restore after week 8. For 10-day concomitant therapy and 10-day Bismuth quadruple therapy, the gut microbiota do not restore completely even after 1 year. We also check the antibiotic resistance. We use E. coli as an example because E. coli is the most frequently isolated in stool sample and most frequently in our GI tract. As you can see, at week 2, 14-day triple therapy and 10-day concomitant therapy will increase for certain antibiotics, especially beta-lactam, because these 2 regimens contain amoxicillin. And bismuth quadruple therapy do not have any significant change except for sulfur drug. However, after week 8, antibiotic resistance rate of E. coli completely recovered. So don't worry about Helicobacter pylori will need to increase or other bacteria, for example, E. coli. Of course, in the GI tract we have so many bacteria, but we only just take E. coli for example. And another interesting aspect is the alternation of metabolic parameter. You can see after 1 year, your body mass index increase and the body weight increase. This is statistically significant, but I personally do not have this has any clinical significance because our sample number is so high, so only increase 1 kilo, where where body weight will have study. The most interesting aspect is the insulin level decline and the insulin resistance become better. So even after 1 year, the effect, we have the other beneficial effect. That means decrease insulin resistance. In addition, the lipid profile become better. For example, high density lipoprotein level increase after 1 year. And overall, the metabolic syndrome do not have any change after 1 year follow-up. And in community, it is important if the reinfection rate is high, such screening and the eradication where the effect will be decreased. So we also follow up the reinfection rate. Actually, the reinfection rate is 1 to 2%, so that is not so high. In conclusion, our experience suggests the strategy of screening Helicobacter pylori and the mass eradication in a symptomatic population can reduce occurrence of peptic ulcer. While you will have dramatic reduction of 70% to 80%. And after 12 years follow-up, the reduction of gastric cancer is about 50%. We have also developed optimal first line and rescue therapy of Helicobacter pylori eradication based on local antibiotic resistance and the randomized clinical trial. The antibiotic resistance of E. coli and the prevalence of metabolic syndrome will not increase 1 year after Helicobacter pylori eradication. And the perturbation of gut microbiota appear to be restored with time, but the speed and the extent of restoration vary with different regimen. And the perturbation of gut microbiota may lead to other unexpected beneficial effect beyond the stomach. So this is the final slide. When I was a medical student, our microbiology usually teach pathogenic organism. However, now is in the era of gut microbiota, we should put our attention to those commensal. And if you have poor diet and use of drug or poor lifestyle, we need to alteration of gut microbiota. And this commensal may become pathogenic. So our medical biology classes should focus not only on pathogenic organism, but also on commensal. All this work are done by my team. Without their help, I cannot stand here. And also, today, because today is Teacher Day, I want to thank you, Joseph Song, or other teachers sitting in the audience. And we also thank you for the support from our Ministry of Science and Technology and the Taiwan Clinical Trial Consortium. In particular, we want to thank for participation and colleagues. And welcome you to Kaohsiung. This city is famous for not only seafood, but also famous for his good weather, although the weather is hot today. But the people here are very warm. Thank you very much for your attention.
Thank you very much, Professor Wu, for a very interesting talk. We'll now open this for discussion. So while you're coming forward to the microphone, can I ask you two questions, Professor Wu? In relation to your very interesting paper coming out in the Lancet Infectious Disease, you suggest that different regimens of anti-Helicobacter treatment may have different effects on the dysbiosis of the gut. Are you testing the gut microbiota in the stomach, or is it from the stool sample, which means that it is dysbiosis in the whole gut? And also, my next question, which is related to this, is that do you think this change of microbiota due to disappearance of Helicobacter, or is it a result of the antimicrobial drug that you use?
Two outstanding questions. For the first question, we do not analyze sample from stomach. That means we do not analyze gastric microbiota. For the second question, we need a control group do not have received antibiotic eradication. However, we try to analyze more in depth to different kind of regimen to different bacteria, and we wish to provide some clue for for future studies.
Is there any questions from the audience? Dr. Graham, I think you will have a question. Or Professor Francis McGraw, do you have any question? No question. Okay, if there's no question, we'd like to thank you once again for your excellent talk, and I'd like to present to you a certificate on behalf of the society.